Good afternoon, everyone. On behalf of myself, Wendy Spearman and Mark Sondra, we welcome you once again to our weekly COVID-19 ECHO clinics. And once again, we thank Project ECHO of University of New Mexico for expanding our license to really run these really important clinical and epidemiological updates every week. In the room together with me, I've got Renee Krause and Jackie Hall, who are joining us. Renee's one of our main speakers, and Jackie's on the panelists. And Graham Mankeys will be chairing the session as usual. So over to you, Graham.
Thanks very much, Wendy, and welcome to everybody to this week's webinar on COVID-19 hosted by the Department of Medicine at UCT on the Project ECHO platform. So we've got a very important topic, key to our comprehensive clinical services to cover in our main talk this afternoon, which Renee Krause will be giving on palliative care. But we're going to follow our usual format, which is a brief update on the epidemic in the Western Cape, followed by the main talk and then a panel discussion. So I'll hand over to Andrew Bull. Andrew, as you know, is a public health specialist working both at the Western Cape Department of Health and in the School of Public Health at UCT. And Andrew's going to give us a brief update on the epidemic in the Western Cape. Thanks, Andrew.
Thanks, Graham, and greetings to everyone. So the update will be fairly quick this week. There's no special or unseen analyses. So these are our standard reports showing the evolution in testing and cases, hospitalization and mortality. And we've presented variations of these graphs many times over the weeks. So there is a trend of a downward trend in the number of tests from both public and private sector, private being blue and public being green. And the positivity has trended downwards slowly, but substantially over the last couple of weeks. It had at what was our period of greatest service pressure, it was almost at 40%. Of tests being positive, and it's now down to about 25%, which is quite a shift. And consequently, we've also seen a decrease in enumerated cases, gradual but steady, and it's mirrored by a decrease in the number of healthcare worker infections as well. Hospitalization as well, we've seen a decline in probably more a slight in public and private sector, and in both ICU and in general beds, not in the PUIs, but our confidence of the ascertainment of the PUIs is not that great in terms of the coding of the specialty that which is how we determine it. And then on the mortality, the blue are the deaths on the date of death as recorded on our systems. And the red dots are as reported. So when we report it, sometimes a day or a couple of days after the event, the reported deaths are less likely to have under-reporting at the end because the delay should be consistent over time. And then the black dots are taking into account some adjustment made for anticipated late reporting, and also the adjustments made for what we anticipate are COVID deaths that have been missed because they weren't recorded based on our comparisons with the population register. Just if one looks at these red dots and black dots, there's a period of the relative stable numbers in spite of us feeling and the easing of the pressure on the metro. The numbers of deaths have not come down as precipitously as might have been. And a couple of times on previous calls, we've mentioned that there's a bit of lumpiness in the how the epidemic is playing out throughout the province, and that the provincial picture may be a bit of a composite. And on the last call, Marianne showed how different sub-districts had left the kind of exponential growth at different times. So to take that a little bit further, I can just advance the slide if someone can do it for me, because it's not, yeah, there we go. Yeah, so this one just demonstrates that when comparing to the population register, that period, whether we take cases, mortality that we've enumerated ourselves, or we add our anticipated additional estimates, or whether we take the population register. The population register is a bit more variable, but demonstrating the same high level. This latest number is, that report will come out this evening, but it substantiates the ongoing levels of mortality, and the reason why it fluctuates more than our own numbers is because it's being compared to this baseline, which is fluctuating. But all just to make the point that this picture that where the RT, if you calculated the net reproductive number, we calculated it backwards from mortality, would have been hovering around 1 for a good 5 or 6 weeks. Next slide. So, looking back a couple of weeks at the proportion of the deaths coming from the different sub-districts, Klipfontein and Khayelitsha have fallen from just below 40% to below 15%, and there's a couple of districts that have taken up that slack within the metro. Eastern has come up, although not as much in the last week, but we can see a number of the non-metro sites are recording more clinical events now than they were previously, and that partly accounts for the plateau in spite of the substantial easing of pressure that we felt in the metro. Next slide. And so when we look at this, when we look at it over the full time course by sub-district, we will see that quite a few of the sub-districts over that same period, although most of them are plateauing or coming down now over that period of 5 to 6 weeks, they've either gone up or they're in that middle section where they've been fairly consistent, or especially with Khayelitsha and Klipfontein have come down quite precipitously. So for the modelers to fit this pattern, taking out the differential contribution of different sub-districts, imagining that we all followed one of these patterns, they've had to put in place, they've had to make quite dramatic assumptions about the proportion of the population that either is infected with milder or asymptomatic infection, or that are not susceptible for the various reasons that have been discussed, or differentially susceptible, or make different assumptions about the effectiveness of the non-pharmacological interventions that have been put in place. And the model fits that we've received that start to come close to emulating our trajectory assumed that 2/3 of the population were not susceptible. And whether you reapportion that 2/3 to mildly symptomatic or asymptomatic, or you make differential assumptions about NPRs, it does reflect quite dramatic assumptions that have to be made about the epidemiology that hadn't before been able to be estimated from any direct evidence. We can go to the next slide. So I noticed these two reports both coming through this morning on serology in two different global settings. A study from the US showing that at going back to early May, the seroprevalence on a survey there was close to a quarter, and one is not reported in a study as yet, but reported in the media from Delhi, and it wasn't clear. It sounded like they reported in the article 29 million people, which is Delhi state. Similarly, a quarter of the population being seropositive, and so that's two completely different settings with very different abilities to respond to lockdown measures, and about an 18-fold difference in mortality between those two settings, yet having the same seroprevalence. So it really shows how why there's such intense interest for ourselves to try and understand what is happening from a serology perspective. We can go to the next slide. So just to just update everyone on where we are with that. So the NICD have let us know that with the HSRC, they are planning a national serology survey, and they're going to, in order to achieve adequate yield, they're going to work in the four metros and 4 provinces that have been most affected, including Cape Town. It's currently a relatively small sample size. It's only really powered to give an estimate for the whole district. And so we've only just received the protocol, and we'll be engaging with them to see whether we can harness that activity to get a little bit more data that might, and maybe to subsample one of our higher burden sub-districts more intensively. There's also a sentinel site for respiratory pathogens in Mitchell's Plain, and they are planning in September to add serology to a survey that they were planning to undertake anyway. And then last week we heard about the serology tests that were being validated in the Grooteskier virology lab, and virologists with epidemiology colleagues are planning surveillance of residual sera from routine collected antenatal and HIV specimens. And if we manage to get both the population data and the routine data together, we'll be able to work out what the biases are. And this second approach might prove to be a very efficient approach for monitoring trends in population infection over time. And the last slide is to acknowledge the teams that we work with responding to the outbreak and in the Health Impact Assessment Unit. Thank you very much.
Great, thanks very much, Andrea. And that's really useful update and give us insight as to where we might be going. And we look forward to hearing about some of the updates of the seroprevalence surveys, because it's only once we have that data that we'll have any certainty as to where we really are in the epidemic. And look forward to further updates. So thanks very much. So we'll move on to our main talk this afternoon. Just to kind of start out and introduce it to say that a critical area of our comprehensive response within the clinical services to COVID-19 is palliative care. And we know that deaths are occurring in our services despite intensive management. And some patients, due to pre-existing comorbidities or poor baseline functional status, are not eligible for intensive care or for high flow nasal oxygen. And when they enter our services can be predicted to have a fatal outcome. And dealing with issues around dying, providing optimal medical and psychological palliative care support, and interacting and supporting families during this difficult time, we regard as a key aspect of our comprehensive services in the context of the COVID pandemic. And to address the issue of palliative care in the context of the COVID response, our speaker today is Renee Krause. Renee is a family physician with a master's degree in palliative medicine and a postgraduate diploma in health professions education. And she's a senior lecturer in the Department of Family Medicine and Public Health at UCT, and a convener of the postgraduate diploma in palliative medicine at UCT. And Renee has played an enormous role in providing clinical input and guidance, working alongside colleagues and staff in the COVID wards. And she'll share some of that experience today and some of the guidance that she's offered. And it's really a great opportunity to have Renee sharing that guidance with a wider audience today. So thanks very much, Renee, for all you've done in the service and for agreeing to talk this afternoon. So over to you.
Thank you, Prof. Thank you for the Department of Medicine for giving me this opportunity to talk about our experience of providing palliative care during this pandemic. But I think I've got to start by firstly acknowledging the Department of Health of the Western Cape, who's really actively tried to integrate palliative care and the palliative care task team. And of course, my own palliative care team at Groote Hospital, who've been working tremendously hard during this time. And I also want to just acknowledge the Palliative Care Practitioners Association, who are working across South Africa trying to integrate palliative care into the COVID response. So at the beginning of this pandemic, already in March, it was evident that many people and many patients were going to suffer due to this disease, and that palliative care was going to become an integral part of the services provided. But what does it actually mean? I think what we forget is that palliative care starts at diagnosis, and that palliative care doesn't only include end-of-life care, but it becomes more important as you realize the curative approach is not working. And especially during this time, we realize that bereavement care is going to be and is still a very important component of the palliative care provided. Within the African context, we always realize that we need to include the care of vulnerable children. And reflecting back on what we saw over the past few months is that it actually should be extended to including the care of the vulnerable old people. Many old people have become and left behind, not with carers, and themselves in having COVID, and need to be included into this comprehensive care that is provided. So what are some of the basic principles that we have to remember when integrating palliative care? It includes the care of the patient and the family. It includes end-of-life care, but is not solely end-of-life care. It provides relief of symptoms despite the outcomes. And it intends neither to hasten nor postpone death. Palliative care is not euthanasia, and it must be provided alongside standard or curative care. Palliative care is not an excuse for poor care, and wherever we started to integrate palliative care, we made sure that oxygen was going to be provided in the wards that were going to deliver palliative care. And I can't overestimate it that it is really important to provide it alongside the care that should be provided for patients with COVID. The World Health Organization also strongly recommended that palliative care be included in the COVID clinical response. And in this document, they also alluded clearly that it's not just end-of-life care, that they strongly recommended the inclusion of advanced care planning, and started to comment on the use of low-dose opioids in caring for patients with severe respiratory distress. This document also gave palliative care therapies that should be available in the clinical environment when delivering clinical COVID care. So we were very fortunate to work with the Palliative Care Practitioners Association, who developed through consensus and working with international documentation on a clear clinical care pathway and clinical care that should be provided within the South African context for patients with COVID pneumonia. And together with Juanita Arendse at the Department of Health, we were able to align the clinical guideline with an operational guide to implement palliative care. What's very important about this document is that you need to ensure that palliative care is provided throughout the continuum of care. And palliative care was therefore integrated into the field hospitals and into the home care response. What we have reflected back on is that it's not been that easy, because many hospitals are not sensitized to palliative care. And in a hospital, for example, like Mitchell's Plain Hospital, it's been much easier to integrate palliative care because they have senior healthcare providers already trained in palliative care and who have been doing it for a long time. Yes. So the first question is, who actually needs to be referred for palliative care and who needs palliative care? So there's a lot of international tools that can be used to integrate palliative care and identify patients who require palliative care. And one of the documents that we used before COVID was the supportive palliative care indicator tool. In Groote Hospital, we adjusted it into our referral forms sort of to highlight clinicians to who should be referred for palliative care. But throughout the years, we've realized that this document actually does not catch up all the patients in the South African context who actually require palliative care. And through consensus in the past few months, we have included 3 other main conditions. Firstly, trauma, especially severe burns. We've also included hematological diseases. And of course, unfortunately, we actually started thinking about this, were infectious diseases. So who actually in the COVID pandemic require palliative care? And I think COVID falls better under infectious diseases. And I like the statement that we have developed through consensus here at UCT is deteriorating clinical condition, failing best available treatment. Therefore, it does not put it in a specific place. Therefore, palliative care can be provided within the wards and within ICUs and across the continuum of care, looking at best available treatment. So it's very context specific. International guidelines are talking about COVID patients are critical when their respiratory rate is over 25 and when they have a saturation of less than 88% despite oxygen therapy provided. So if you look at who do we also see are critical COVID patients, we can see that for mild and moderate patients, we do need to improve the psychosocial care and the symptom control. But as COVID becomes critical, palliative care does become more urgent. And I think here the critical COVID patients are reflecting on working in ICU and including the families. This has been very important in the clinical COVID response. But if we know that the patients are most likely not going to make it, palliative care referral becomes urgent. Okay, so what have we done in Grootes Schuur Hospital? Firstly, and most importantly, we are a small team. We had to collaborate. Unfortunately, a lot of the collaboration has happened before the COVID response. As stated before, we have worked closely with the Department of Health, with emergency medicine, with family medicine, and now with psychiatry, psychology, and with social work. We have tailored the tasks according to skills and exposure risk. And during this time, we've been very fortunate to work with psychiatry, palliative medicine, family medicine, to increase the boots on the ground. So people who are actually seeing patients. We were very fortunate to have a family medicine registrar joining us to assist on being boots on the ground to actually see patients. We were also very fortunate to be supported by the project Team Care, who has provided us with resources like smartphones and data. So what care have we provided? And this is just for the month of June, where we saw about 93 patients in the team. I must also say that a lot of the patients we already have enabled clinicians in the wards to see the patients on their own. So new patients with COVID, we saw 53 patients, of which 27 of those patients were for end-of-life care. Then we continued seeing patients who are non-COVID, and I do want to just speak a little bit about these patients later in the talk. We also did bereavement calls, 49 bereavement calls, and 82 family meetings through telephonic calls. The comorbidities of the COVID patients that were seen were mainly, as expected, the heart, diabetes, high blood pressure, CCF patients, but also renal failure patients. And again, I want to say thank you to the renal team at Grootes Schuur, Dr. Professor Word, who previously had worked with us to develop a clear guideline to provide care for renal failure patients and the palliative care of these patients. What I also want to talk about is that we saw 3 patients in the COVID wards suffering from complicated bereavement because of multiple losses. And again, thank you to psychiatry and psychology that we could actually provide these services for patients. So I think as clinicians, we need to be able to provide symptom control. You will not be able to always have access to a palliative care trained doctor, and most clinicians should be able to actually provide symptom control. Internationally, a lot of guidelines have been developed to provide the care. What most of these guidelines actually have in common is that you need a rapid palliative care response. That the three main symptoms that we are dealing with are dyspnea, distress, and pain. And finally, that low-dose opioids are recommended for the use of patients with dyspnea at the end of life and patients who have dyspnea or severe dyspnea. For this talk, I'm going to concentrate on our document that we created with the Palliative Care Practitioners Association. I am not going to go through this document in detail, but it is available on the PALPRAC website as a one-pager that can be printed out. This, in a UK study that has just come out, they looked at retrospectively at the dosages of opioids in midazolam used, and it correlated well with the document we have developed, where at the end of life, when patients are severely distressed, 15 milligrams of morphine over 24 hours subcutaneously and 10 milligrams of midazolam subcutaneously. And I think it is over 24 hours that we've also, through strong collaboration with the hospital, and we have been able to actually get palliative care syringe drivers in the wards that will be released as soon as possible. These are not expensive devices and help us to deliver the medication when patients are not able to swallow. So the first and most distressing symptom has always been delirium. It's very distressing to observe, and it negatively affects the therapeutic interventions like oxygen delivery. Patients take the masks off, they are climbing out of the wards, the beds, so it's not easy. I think, and that's why it's been very good to collaborate with psychiatry and psychology to be vigilant to diagnose delirium and to document it. To obviously try to reverse the reversible if possible. But one thing that repeatedly comes through in studies and that we have known clinically are that the non-pharmacological interventions have repeatedly demonstrated to be superior to any drug to contain the delirious patient. Now, non-pharmacological interventions are not easy in a COVID ward. However, simple things do help. So firstly, remove the distressing factors like pain. Make sure you have tried to get one healthcare provider to talk to the patient, and when you are talking to the patient, to orientate them to time, place, and person continuously. Physical restraints are not recommended and may worsen the agitation. And it is important to assess that delirium on a daily basis, not just by asking or interviewing the patient, but speaking to the nursing staff and the other patients sometimes in the ward to find out actually how the patient is doing. And if possible, actually to speak to the patient, the family, to how the patients are doing. Okay, so medication to contain the delirious patient. Start with haloperidol, low dose, 12 hourly, and can be increased. And our second line drug is olanzapine that can be also used 12 hourly orally. You have to know that there's a very distinction that there is between delirium that we're trying to reverse the cause and when we are dealing with terminal agitation. And for terminal agitation, the midazolam as a short-acting benzo that can be provided subcutaneously is the drug of choice. I want to again refer you to the PALPRAC guidelines and to how to use syringe drivers to deliver this drug. If the patient is actively dying, we need to ask the difficult questions like, are oxygen masks really needed, which can distress a patient even further. So, shortness of breath or dyspnea, which is the subjective experience. So when the patient is actually telling you, doctor, I can't breathe, I'm feeling anxious about it. And as stated, oral morphine remains our first drug of choice to manage this. But what we have to remember is that it is a low dose, not to give more than 2.5 milligrams orally. You can also, of course, provide it subcutaneously, but remember the antiemetics that need to be provided with those patients when they are given any opioid. Okay. Pain, and when we are using continuous subcutaneous infusions, as said before, we require syringe drivers, and to provide low-dose opioids as a starting dose over 24 hours, and to decrease the dose in the elderly and if the patient has renal failure. If the patient is on opioid already, for example, cancer patients, the dosages can be increased. If you feel you are providing too little of the opioid, start thinking of providing breakthrough dosages and that can be prescribed for patients, and write it up, especially if you're working with senior nursing professionals who know how to deliver these drugs. It also gives them the freedom just to then give the drugs. Okay. Unfortunately, we also need to look at providing end-of-life care during this pandemic. And end-of-life care requires comprehensive end-of-life care. Firstly, as clinicians, we need to know that there's always something we can do for patients. Look at the medication, make sure you are prescribing the right route of medication. Patients who are dying cannot swallow. Rationalize medication. As I always tell the medical students, you do not have to die taking iron sulfate. And write up drugs for anticipated symptoms. You know patients may become restless at the end of life. You know that they may develop pain. You know that they may have nausea and vomiting at the end of life. So rather write it up as a PRN dose that can be provided rapidly to patients. Review the place of death, which is difficult in the time of COVID. However, I know of family members who've emailed us and asked us, please can we send this family member home? And at the CTICC, I know of patients who were taken home because the patients come from the environment of the COVID. And if there are family members who are low risk, who can look after that family members, we still have to review the place of death with the family. Review investigations and your nursing procedures. The most important nursing procedure that needs to be provided is mouth care. Patients talk through it. It is a very visual thing for patients and families, and especially now that we are doing video calls to families, please look at the mouth for patients. Offer spiritual care, and we've been very fortunate to work with our spiritual carer here, who has been providing telephonic spiritual care. But very important is to work with the relatives. They need to be informed about the seriousness of the illness. They need to be counseled, and they need to be kept updated on what is happening with this loved one. So reflecting on managing end of life during COVID, patients deteriorate quickly. As I said, even if it's quick, we can still do a lot for patients. Identify the dying patients and manage that agitation and delirium. Communicate with families. Families get angry if they do not know what's happened. And follow those patients up. And very important, in the COVID wards, reflect back with your teams. Many of the team members are very young, and many of the team members are actually from disciplines who are not used to working with dying patients. So they find the whole process very distressing, and they need to be debriefed. Psychosocial support for patients and families, and I'm very fortunate to work with strong psychosocial carers. Explore with the patients and the diagnosis, their fears, their hopes, their spiritual needs. Techniques like mindfulness and the simple acknowledgement on fears and letting them talk about it is so important. We contact families so that they understand the diagnosis. There are still, unfortunately, a huge amount of stigma around COVID, and concerns around the prognosis. Family members also have to reflect on their own health status, and if there are family members in the home that also require extra care. General information around how to contact the wards. There is nothing as angst-provoking as when you are phoning a ward that your loved one is in and nobody answers the phone. So we have to be thinking of a wider way of informing patients. And of course, offering the families also spiritual support. I think one of the main parts of palliative care is compassionate communication. And this is a tool that must be used as a competency, as a skill that healthcare providers need. So here are a few sort of important things to think about when you are communicating with patients and families. Check understanding. You will be surprised at the misconceptions of patients and families around what is happening. Give information, small chunks, and avoid medical jargon. High flow nasal oxygen is medical jargon. Families do not understand that. Use silence, and what we are teaching healthcare providers is to use an empathetic response to patients. That means you are acknowledging emotions. And the NURSE acronym is a very nice tool that can be used to actually teach you to acknowledge emotions in patients. So, which looks at naming, understanding, respecting, supporting, or exploring emotions. Another aspect is be truthful, not to underplay the seriousness of what is actually happening. And never ever use these sinful words that there's nothing more that we can do for you. Commit to care. Consider linking the family, as we have been doing with telephonically or online, to say a final goodbye. But before you do the phone call, first talk to the family about what they are expecting and whether they actually want to do it. Some people actually do not want to do it, and you have to sort of orientate the patient family about what to expect when they see it. And we've been, of course, using tablets and WhatsApp videos to do this. So this is a very interesting tool that we are really promoting, which is the Vital Talk guide. And what this tool makes sure is when you are communicating is firstly to respond to the emotions, to be truthful, and also then to ensure a follow-up or continuity of care somewhere. Simple things that a person can remember whenever you are having a conversation with families and patients. Okay. Apart, as stated before, we need to provide bereavement care. One of my colleagues at Mitchell's Plain Hospital, Dr. Patrick Szymanski, said he thinks one of the biggest complications during this pandemic is going to be complicated bereavement. We are doing it at the moment, a week after the death, and starting with a simple "how are you?" But it's about understanding and addressing misconceptions. Families need practical advice around funerals, etc. Very important to assess the support structures and to identify vulnerable people in those families. Multiple losses, vulnerable children, and as said, other family members, and looking at pre-existing mental illness in patients and families. What we've learned is also make sure you're talking to the right family, and if possible, get collateral information from the treating team. And I think the treating team needs to know they sometimes need to be available to actually speak to the families afterwards. Families have had multiple losses, and it's traumatic for families. And families also need facts like funerals, contact details, all these things that need to be provided to families to go forward. A very important population are children, and children might require specialist bereavement. And we are fortunate to have an organization called PEDS-PAL that is available to actually provide specialist pediatric bereavement, and pediatric is also teenagers, for children who have lost loved ones. And of course, to have community and psychiatry referrals, And I was very happy to see a community referral form coming out in the Western Cape, that we have now a structure to refer patients and families for bereavement in the communities. Okay. So reflections from managing known palliative care patients during the COVID pandemic. And I do think we all need to be aware of that. These patients haven't gone away. They are high risk for exposure to COVID. They need to use healthcare facilities, and they have many comorbidities. Usual home care is not functioning like usual. And patients and families are feeling very isolated. Doctors are not speaking face-to-face with the families, and this makes it even more frustrating and confusing for families to actually deal with what's happening. Therefore, please anticipate symptoms and send patients home with enough medication and a very clear follow-up plan. Document decision-making and who was spoken to telephonically. Communicate and document communication. So please document it. Get the patient out of hospitals as soon as possible. Unfortunately, a few of our patients, palliative care patients, actually developed COVID in hospitals. And ensure the organization you are referring to for home care are actually providing the home care. So key lessons learned: work alongside known palliative care services. Palliative care is a complex intervention. It might seem simple, but there are some very fine nuances that people need to be aware of. Widen the reach of palliative care by collaborating and working and reassessing your services continuously. Ensure key palliative medication is available in all wards. They were not available in all the wards at the beginning of the pandemic, but now they are available. Staff need to be trained to manage delirium, dyspnea, and end-of-life care. And families, although we're not seeing them, remain vital to the care. They must be educated, counseled, and supported. This is not easy work. Support each other. Thank you.
I've been unmuted, Mark, is that correct?
Yes, you have, Greg.
Thanks very much, Rena. That was a really excellent overview, and for providing those insights and your reflections on the work at Groote Schuur and the practical guidance. And I really just want to pick up on one of the things that you said, that a lot of what you've spoken about today are kind of core skills that every healthcare practitioner should take on board. And I think there are only a few good things that have come out of this COVID pandemic, and one of them, at Groote Schuur at least, is that I think that it's given an opportunity for colleagues who wouldn't usually learn about palliative care to interact with those who have the expertise in that, and take on board some of these skills, important lessons around palliative care. So, again, thanks for the work that you and your colleagues have played in enabling that. So we're going to move on to our panel discussion, and to welcome the two panel members who are colleagues from Groote Schuur and UCT as well. Firstly, Zainab Mohammed. Zainab is the head of clinical unit in radiation oncology, and obviously has expertise in palliative care from her work in cancer, and has worked alongside colleagues in the COVID wards, alongside colleagues in medicine, sharing that expertise. And then Jackie Hoare, who is head of division and of consultation liaison psychiatry at Groote Schuur and UCT. And Jackie has both worked to support the palliative care that we've been offering patients, but also supporting staff and patients with psychological and psychiatric support. So I'm going to open it up first and ask Zainab if you want to add any insights, and if you've got any questions for Renee to open the discussion.
Good afternoon, everyone. And firstly, I want to thank Renee for an amazing talk. You really covered all the bases. And I feel that this is actually long overdue, but in the Western Cape, we had such a steep increase, and we all just had to scramble to deal with what was happening. Hopefully now, with things sort of easing down, there'll be more time for this type of communication that needs to happen. For me, the one thing about my 2 weeks in the COVID ward that really impressed me was that patients were getting excellent management. But the one thing that I found a bit scary was that there wasn't a lot of communication with families. And in fact, there were people who would phone and their family member would be deceased and no one would have called them to give them that information. And then I discovered that it was one intern that had to do this for so many wards. So my first question to Rene really, because there's a lot of really junior staff that needed to break this bad news. How much communication training do medical students actually get at UCT? And also then for Jackie, I just wonder how the interns and the young doctors are coping with death and dying, but not only young doctors, because I know there are many senior doctors who also find it very difficult to break bad news.
Thanks, Zainab. So, Rene, do you want to respond?
Thank you, Zainab. So, communication is integrated. Communication skills are integrated in the undergraduate curriculum through family medicine, and it's definitely in the first year and then revisited as a core competency in our final year exit OSCE. However, unfortunately, many of the people come from universities that don't always have communication skills, and communication skills is something that needs to be practiced and relearned and actually needs to be revisited, what I feel, as registrars as well, because these skills need to move from breaking bad news to actually having more complex types of discussions with patients and families, especially when you start thinking of doing advanced care planning and advanced discussions with patients about future care, which can be very complicated.
Thanks. And Jackie, so the question from Zainab, and I think it gives an opportunity for you to make any comments that you have, about palliative care, but also the psychological support for staff and the psychological burden on staff that you've observed.
First, I'd just like to make a comment that the work that Renee and her team have done have really highlighted the importance in shifting our thinking from there is nothing that we can do to there's so much that we can do. And this has not only been helpful and of course helpful and incredibly meaningful for the patients themselves in managing their distress and their agitation, but it's also incredibly meaningful for the families. But it has had a positive effect on our young doctors, which leads to Zainab's question. For the young doctors to be able to shift their thinking from a there's nothing we can do to there's something we can do, shift their position from one of helplessness to them having some kind of tools or position of being a bit more empowered to deal with an obviously very distressing situation. Renee did highlight that there is so much we can do a little bit in her talk, but I would just like to emphasize it again. And the importance that we do carry that through to our trainees and young doctors, that end of life isn't withdrawing. End of life is actually an incredibly active process, and we've learned so much from Renee, and I really believe that it's important to enforce that. But to answer your question directly, Zainab, in the support groups that we have done across the hospital, the most common thing that the younger doctors, junior doctors, registrars, interns want assistance with is talking to families. It is an incredibly overwhelming experience, not only, of course, in dealing with your own feelings and your own anxieties about witnessing morbidity and mortality in a way that we haven't done that before, but then having to counsel families and having to do that over the phone has also made it incredibly difficult. It is a difficult thing. It's so much easier to show a family member your own feelings, your own empathy, your own experience of their loved one. If you're in person, but doing it over the phone is incredibly hard. And one of the ways in which we've really been able to support doctors is that we've taken on a lot of that work. We don't give the bad news initially, but what we are doing is picking up when it's a really difficult conversation. So we've tried to take that burden away from them for the time being. Obviously, there are skills that we need to build on, but for right now, and when everybody's really distressed, to being able to take that burden away of dealing with the really difficult families, when the conversation really hasn't gone well, we've managed to sort of take over and assist there.
And I think we've seen this also when we have had a lot of complaints coming back. It's about simple communications that just need to be revisited and to take through misconceptions that need to happen. And that the ward staff are so busy that they actually don't have the time to always talk to families.
Yes, I'd just like to comment. I hope that what everyone has seen, all the doctors and the senior physicians that are managing COVID patients, is how important palliative care is, the role that it plays, and how important communication is, and especially as far as management is concerned, mitigating complaints, because what it actually does is it improves the patient experience or the family's experience of their healthcare. So yes, thank you once again, Renee.
Thanks for that comment, Zainab. And I think that, as you point out, Zainab, is that it was things were happening at kind of lightning pace during the exponential growth of this epidemic, and there might have been gaps that occurred, but now we're entering into a phase of a kind of chronic epidemic at high levels still, but we might be able to improve further some of the systems that we have in place, and I think that's important to point out.
And maybe also important for the aftermath.
Yeah.
Because we're going to see a lot of people chronically affected, not only with bereavement, but actually with physical issues related to their COVID pneumonia.
Mm-hmm. Yeah. So Renee, can I just ask you if you can just elaborate and just give a kind of a bit more detail to how you went about facilitating the video interactions between patients that were dying and their family members, and some of the practical steps that you took, some of the challenges, what your experience of that was, so that for colleagues at other facilities who could potentially do something similar, your experiences.
Firstly, I will tell you we've made many mistakes. Okay, so we haven't got it perfect, but what we have learned from, and it's a new way of talking, but what we have learned from is making sure you're speaking to the right people first. Although you've got the number of someone, is this actually the person you should speak to? And to gauge their perception and asking what do they know, who's been speaking to them. And sorry, even before that, actually to make sure you've spoken to all the team members, and I'm not just talking to the doctor who's sort of giving you the referral, but many times nurses in the wards or interns in the wards have actually had interactions with the family. So you need to sort of get this background information about what has been told to the family. Then when you do speak, then getting their perceptions, and from the perceptions you need to know sort of, are you going to break the bad news to them, or will you be able to go ahead with this talk, and do they understand the seriousness? And asking firstly permission. Not, as I said before, not everybody actually wants to see their loved one, and to normalize it afterwards. And sometimes family members will tell you, but what do I say to my loved one? And then it's those difficult conversations that, it's sometimes just a simple I love you and a thank you that needs to be said. And also hearing about their fears before they go and speak to that family member, so that you can address those fears already before the time. And after the phone call, to make sure you follow up perhaps a day or so later with what has been said and how they are doing.
Right, thanks. So Mark, there are questions from the chat room. Do you want to expand on them?
Thanks, Graham. Yeah, there are a few. There's been a debate raging about the availability of IV haloperidol, which we've ranged from being out of stock to suggestions of use of droperidol, to saying there is haloperidol available but at higher strength. So I think the guidelines were talking about oral haloperidol or olanzapine as a second line. Is that correct?
Yes, but if you do, you can also provide haloperidol subcutaneously.
Okay. So it is available, but at higher strength.
Yes,
but
we are fortunate to have it.
But there is an IV availability formula issued in the country as general. So is droperidol a reasonable alternative?
Yes, we've used droperidol successfully. So if you aren't able to access haloperidol, droperidol is a feasible option. And we've had some pretty good successes with it. It's a little bit more sedating than haloperidol, but the dosing and the response is pretty similar. So 5 milligrams of droperidol is equal to 5 milligrams of haloperidol.
Okay. Sorry, Grant, go ahead.
That's given subcutaneously. Either of them is given subcutaneously.
Yeah.
Yeah, interchangeably. Yeah.
Graham, there's a question around, are there guidelines that we can use to decide on the safety of which patients can be allowed to die at home? And then a comment from a colleague saying they've heard people say, I don't have time to counsel patients. What is your response to that?
I'll answer that one.
Okay. Well, it's sort of a difficult one, and I don't have time. Jackie.
All right, so I've spent a lot of time with patients with COVID pneumonia who are in the high flow oxygen wards, and these are not people with kind of, for the most part, they're not patients with pre-existing mental illness. These are just regular folk who find themselves in a very difficult, very frightening situation. They're isolated, and it really is quite unique. If we think what a normal medical ward would look like, is you'd be surrounded by other patients that have had different conditions to you. And if you saw somebody being intubated, or if you saw somebody kind of compensating and decompensating in some way, you as the patient could separate yourself from that experience because you had a different condition, for example. This is a completely different, where patients are incredibly aware of everything else that other patients are going through because they're internalizing all of it, because it is so real that it could be them. For the most part, I haven't had to do really comprehensive counseling. I've done short sessions of supported counseling, 2-3 minutes on mindfulness techniques. A 15-minute conversation with a patient has often really shifted things for them. I mean, we've actually seen really measurable changes in terms of their respiratory rate and their SATs by just sort of some brief little tips on how to calm yourself, etc., enabling them to share their story. And these aren't really, kind of comprehensive or intensive psychiatric interventions. These are little things that can happen while you're taking a blood pressure or while you're adjusting your machine. I mean, over and over again, patients are expressing their profound gratitude. They feel incredibly privileged to be at risk here. They're incredibly grateful for the nursing staff and the doctors. They are viewing us as so-called heroes, but they are saying things to me like, I'd really like to know your names. I'd really like to know something about you. I want to know if you have children. I want to be able to ask you a question. Things like that can take 30 seconds. They can take a minute, but they make a huge difference to patients who are lying there and terrified and feeling disconnected from everything else. My overwhelming feeling from all of this is that patients are actually really wanting to connect with us. So we don't really necessarily have to make the time to counsel them, but just giving them those little moments where they're able to connect with us as human beings. I mean, the sort of PPE thing has made the sort of the delivering medical care quite sort of dehumanizing in a way, and they really are trying to sort of wanting to reach out to us, to connect with that human part of us. And if they're able to do that, it's an incredibly therapeutic interaction with the patients, and they love it and they appreciate it and they feel so much better.
And I just want to, it's a compassionate presence is not only therapeutic for the patient, but it's therapeutic for the healthcare provider as well.
Yeah.
And we mustn't forget that actually healthcare providers also are finding this extremely distressing. So to sort of enable them to have the skills to be compassionately present is a very therapeutic tool for ourselves sometimes.
I wonder if I can just go back to the question that we didn't answer.
Can I just make a point there?
I've
I've always regarded, even on the busiest ward round, as a kind of essential part of the medical interaction. You know, even if you've just got a short amount of time to spend, 30 seconds, 1 minute explaining to the patient what the problem is, what we consider their current state for the day is, and that doesn't take a lot of time, but it's an essential part of the patient interaction. And I think, I don't think there's ever a state where we don't have time to do that, because it's just as essential as any part of our medical practice. So, it might be a limited amount of time, but in a few sentences, you can capture a lot of what the essence of the patient's clinical condition is, and fill them in what you feel their condition is relative to the previous day and what they can expect for that day. So, I think that the issue of not having time for counseling, there might not be enough time for extensive counseling, but one can give that patient enough information in a short amount of time that is a reassurance to them, I think.
Sorry, Graham, I just want to come back to that original question and flip side with a similar question, which I think are both excellent. For one was around, is there guidance in safety who can go home to die? The flip side of that question is palliative care relevant in a patient where there's good hope and chance of survival, even though they are seriously ill?
Okay. So let's first look at home care and home dying. UCT is currently working with the ASSET project to look at guidelines for home palliative care for COVID patients, and if that that includes end-of-life care as well. Again, this is developed going to be developed from consensus statement, working with senior palliative care providers who are going to give their input on how to best care for patients who need to go home to die. I do think it's going to be actually a lot like sending MDR TB patients and XDR TB patients home to die. And I can personally remember how we sent the first MDR TB patients to be cared for at home. It is the same kind of thought process that we need to think about. Is there someone to care for the patient? Is there a place? All of those simple things that are not complex, and how are we going to then support that patients once they are home, how to care for those patients at home. Do we need to actually send this patient home with oxygen, and how are we then going to provide oxygen if that need be? Okay, and so your question is,
someone who's seriously ill but has got probably a reasonable prognosis, do they still need palliative care?
Yeah. So I think when we go to that slide I had on the triaging and seeing how urgently palliative care is, and that comes from developed from the palliative care response in a humanitarian crisis. We can start thinking of the mild case patient perhaps only needs symptom control and sometimes only needs psychosocial support, but how, as the curative approach is less evidence that it's going to work, obviously the palliative care approach is going to increase. So yes, everybody needs a palliative care approach. I need a palliative care approach, but sometimes I don't need to be referred on to a palliative care team. And I think it comes down to all healthcare professionals need basic palliative care skills and basic pain symptom control and communication skills to provide that.
Thank you very much.
Okay.
Graham, there was one last question, which I think is an important issue as well, and it was about what has been your experience of the team with debriefing staff members in the COVID wards, and what's the general morale?
Okay, so I think we are very fortunate to work with a very excellent senior psychologist and I hope she's listening, Louise Frenkel. And obviously, she's the person who's been doing this in the wards. I have only been debriefing them informally. So I think it would be an excellent next talk to talk about healthcare, how to look after the healthcare worker and her experiences of debriefing. I have not really been involved in formal debriefing except early on, but once we speak to people, general interns or healthcare providers on how to care for them, it's firstly acknowledging their emotions, normalizing their emotions, acknowledging actually what they are doing. I think healthcare providers sometimes need to be acknowledged, especially the more junior doctors, that they are actually providing excellent care, because suddenly they are exposed to many of their patients dying, and they obviously are asking, what have I done? So it's, and then the difficult part, and I think yes, senior healthcare providers play a very important role in normalizing death in wards. That difficult concept, but normalizing death in an expected patient. So that's been my experiences working with them. And if they need to be referred on.
Anything you wanted to add, Jackie?
Yeah, we've been, Louise Frenkel and I have been doing groups in a variety of different settings with different departments. I have to say that it shifts as the pandemic has shifted. The worries, the concerns, the anxieties, the moods have shifted. With some departments, we actually started the groups before the clinical situation became really overwhelming, and there we sort of dealt with a lot of anticipatory anxiety. Sort of we were watching and waiting and watching CNN and BBC and reading about all the awful things that were happening and wondering when it was going to start happening to us. And many have reflected that anticipatory anxiety was worse than actually the doing. When things just started happening, everybody went into sort of doing mode. It has obviously been very, very traumatic, but I do think it might be a good idea to follow up with a whole kind of session about mental health and yeah, the impact on staff.
Yeah, I mean, just from my side, to answer Keke from KZN's question is, I think maintaining morale of the teams that we've worked with, and that's the teams across the board, the medical teams, the nursing teams, the support staff, to acknowledge the sadness associated with the deaths that we've seen, but at the same time to also reflect on the successes and to constantly remind people that we're aiming to provide the best care possible. And in some cases, that's curative care. In some cases, that's a very good palliative care that we've heard about today. And if we're doing the best that we can under the circumstances, that's the best that we can be asked to do in this context. And when everything's looked at, still one in 5 people is dying in our services, but 4 out of 5 people are being successfully treated and going home to their families. So, that's going to be the experience across South Africa, is that we will have deaths in our services, but there will be many, many people, and more people that survive this, even in our hospitals, than die. And that's important to keep reminding people, is that there are many people that will even though they come into a hospital sick, will survive COVID-19 and go home to their families. So I think maintaining morale is a challenge, but that it's bringing everybody together in teams, as we've many colleagues from UCT have emphasized, and keep reminding people that we've got to remember that most people are going to survive from this condition, and even those people who are sick enough to be admitted to hospital are surviving and going home. And then just to say that in the chat box, there was also a question about droperidol and QT prolongation, but I think Mark Blockman has addressed that one. So to say thank you to Andrew, and then to Rena and Zainab and Jackie. I think we've had an excellent webinar this afternoon. I think dealing with this issue has been long overdue, and I thank you all for your contributions today. And I think it's some important lessons that we've been able to share with colleagues across South Africa. So back to you, Mark, and thanks very much.
Thank you, Graham. And on behalf of Wendy and myself, thank you again for all the speakers, everyone attending. And again, just in the background, thank you to Cheryl Valentine, Karen Fenton from Project Echo Gastro Foundation for their ongoing support. See you all next week.